Again, this is another case series, high pressure, low platelets. This is a very critical combination, a race against time, because this is a medical emergency. So case scenario 1, 27-year lady, 33-week gestation, persistent headache. You can see BP is 168, 97. She has proteinuria, and the proteinuria is worsening from 2.7 to 4.2, and there is abnormal fetal cardiac rate. Case scenario 2, 38-year lady, past history of IUD, second trimester, 24 weeks. Now she is 34-week gestation because of previous bad obstetric history. She is on LMWH, aspirin, secondary prophylaxis. Now she has complaints of migraine, visual disturbances, lethargia. There is progressive thrombocytopenia. LDH is shooting up, and on peripherals here, pathologist tells you that there are schistocytes. The case 3, 34-year lady delivered a healthy male infant at 38 weeks. 3 weeks postpartum, she starts complaining of weakness. BP is shooting up. Platelet is dropping down, LDH is shooting up, creat is shooting up, proteinuria is worsening, haptoglobulin undetectable, and on peripheral smear there are schistocytes. How to manage this? So pregnancy-associated thrombocytopenias amount to almost 5 to 6% of total pregnancies, of which preeclampsia also falls into pregnancy-associated mild TMA if managed promptly. 5%, HELP 0.5%, and TTP 0.05%. Again, this is the timeline. The classical non-pregnancy related TMAs like TTP, complement-mediated HUS, any trimester, whereas pregnancy-associated hypertensive disorders leading to TMA, the HELP comes after late in the second trimester. So classical triad, thrombocytopenia, hemolytic, microangiopathic hemolytic anemia, and any end organ damage, most notably brain, kidneys, GI tract, and heart. So it has implications, huge life-threatening implications for both the mother and the child. And this is a flow chart. So ADAM TS13 distinguishes TTP versus non-TTP. Again, the differential diagnosis, systemic evaluation, ADAM TS13, coagulation parameters, the autoimmune profile, this is all will help you in segregating different etiologies. Again, why this is important, pregnancy specific versus general TMAs like TTP, atypical HUS, because the management totally differs. Pregnancy specific, prompt delivery will most of the times revert these life-threatening sequences, whereas in general TTP HUS, disease-specific therapy. So this distinction is important, like the famous Telugu cinema suspense, Why Kattappa killed Bahubali, fetching highest revenues for Bahubali 2. The more why we ask ourselves, the more wise we become. This is a famous punchline from all our teachers, and this applies to any specialty of medicine. So the details, why, what, how, always help us in saving these lives. So again, HELP syndrome, there are various diagnostic criteria, but most important, stabilization, IV magnesium sulfate, prompt optimal antihypertensives, anticonvulsants, and vigilant monitoring. And eventually, all these pregnancy, hypertensive disorders of pregnancy eventually lead to DIC, and to a hematologist like me, DIC is just death is coming. Contrary to what is portrayed in general public, Madam mentioned about the unfortunate demise of one of our own colleague. Kuch hota hai, this lady is in DIC nicely drafting letters for her daughter for next 12 birthdays. It doesn't happen in clinic. You have to be really prompt to safeguard the life. So you have to really think differently. So pregnancy associated TTP, pregnancy is a prothrombotic state, and it's a major trigger for TTP. Of all cases of TTP, 5 to 10% TTP cases happen in pregnancy, and there are various causes. So always consider TTP in patients with a combination of hemolysis, thrombocytopenia, most notably in first trimester. Again, the classical triad, as I say, doesn't happen less than 10% patients. So SINA-CoAF non for diagnosis, thrombocytopenia, high LDH, and cystocytes on peripheral smear, organ ischemia. These are various organ involved. And the commonest is neurological, 60%, GI 35%. Again, nowadays, most of us carry smartphones. The diagnosis of these life-threatening TMAs is, just few seconds through these kind of rapid algorithms, the plasmic score. Again, management depends. So mostly the timely plasma exchange steroids can safeguard the lives, and after the mother is stabilized, the delivery. Again, pregnancy associated HUS, I will briefly touch base this. The nephrology team has discussed about this. Pregnancy is a complement amplifying condition that may trigger atypical HUS, and this happens most of the times. The commonest, once you rule out other TMAs, the complement testing. And remember, the major challenge with postpartum atypical HUS is these are often preceded by pregnancy complications like preeclampsia 57%, PPH 22%, fetal death 16%. So you have to keep in your mind possibility of subsequent atypical HUS. Successful management of complication doesn't succeed the case here. Again, clinical practice, persistence of hemolysis and renal impairment more than 3 days after delivery helps to identify potential HUS. And remember, the combination of high creat, high LDH, more than 95% specific to HUS. Pregnancy-associated HUS should be considered when there is persistent hemolysis, renal failure in the postpartum period. Of course, because of the overlap, difficult, but most important is pregnancy-associated atypical HUS. Early diagnosis is the key because the treatment is not available in India, and it is for crores of rupees, right? Plasma exchange and corticosteroids are not effective treatment for atypical HUS. In the absence of autoantibodies, dialysis is temporary supportive measure. What is important is complement blockage, which is not available and which caused bomb to the patient. So case scenario 1, so based on this, she was taken up for LSCS with PPH requiring uterine revision and oliguric AKI, platelet drop, schistocytes, Adam TS was high. So this was preeclampsia leading to PPH and then thrombotic microangiopathy, ICU care. I'll share last, there is a very good news for all PPH. A simple injection costing 1.52 lakhs can save more than 99% of the PPH. So that is factor 7. So you see with this intervention, her creatinine and platelet normalized. The second case, this is hereditary TTP, plex, steroids, prompt termination of pregnancy and supportive care. Again, you can see with 2 pegs, the platelet shooted up, taken up for delivery, and both the mother and child are stable. Case 3, 4 cycles of plex, no benefit. So this is atypical HUS. And of course, this is a case when I had the chance to witness when I was in Canada. So 2 cycles of eculizumab, again, complete recovery. So these are, of course, natu moments in high-risk obstetrics, but yes, timely teamwork is important.